nationally with the violence prevention work, and how we hope we can maybe inspire you to start thinking about how we can start developing and implementing and embedding some of the violence prevention approaches and the public health approach within the work that you're doing. So for some people, you might think that that the violence prevention, the public health approach sits only within a health setting, but it's much wider than that, and hopefully you'll get a feel from that from today's session. So as I say, just an overview today. So I'm going to give you a little bit of the background. So I have been working with the Violence Prevention Partnership in the Humber region for the past probably about 18 months. But before that, over the last 4 years now, I've been commissioned by the Royal Society of Public Health and NHS England to work on a national programme about embedding violence prevention and reduction across the NHS. So this is where the public health approaches have been tested and rolled out, and there is a national movement now in the NHS around the public health approach to violence prevention, and we're going to explore what we mean by that a little bit more as we go through today's session. But just to give you a bit of background as to why this work came about, and I'm sure this won't be a surprise to any of you when we look at some of the statistics that come out of healthcare, and we know that they can be kind of attributed to other emergency services as well. But in the NHS staff survey, we saw that about 15% of NHS staff experienced at least one incident of physical violence in the last 12 months. When we roll that out to our colleagues in the ambulance sector, paramedics experienced up to between 31 and 32% violence incidents in the last 12 months. And this was some of the work that really pushed forward the public health approach, because what we know was what we were doing before wasn't working. So we wanted to start looking at some alternative ways of trying to reduce the amount of harm that we see across not just health, as I say, but multiple sectors as this work continues to roll out. And what the data and the evidence also flags is that we know people with protected characteristics are more likely to experience or be victims of violence and abuse whilst undertaking their work. Just a reminder, people not familiar with or haven't thought about the protected characteristics for a little while, I've just thought I'd pop them up here. The most recent ones, so the protected characteristics came in as part of the Equality Act in 2010. They were updated in 2012 with the addition of the 9th protected characteristic, which is gender reassignment. So just a reminder of those there for you. And when we think about the public health approach, how does it differ to the approach that has previously been taken? So when we look at the NHS, we see that it's transitioning really from a zero tolerance approach to a public health approach. And the reason for that is that evidence does show that tackling the root causes is more effective than just focusing on punishing incidents after they've occurred. And like Pip just said in the introduction, what we're talking about is preventative work, which is taking a new and preventative, early intervention approach. But also it's quite complex because we want to look at the root causes, which means unpicking layers of quite ingrained health inequalities, and we'll look at that a little bit more as we go through. So it's an approach which is proactive rather than reactive. It addresses underlying factors such as trauma, mental ill health and environmental stresses which may contribute to violence. And as I say, NHS England commissioned the Royal Society of Public Health and We Do Wellbeing to design and deliver a training pathway. So there are actually some new qualifications at level 3 and level 4, which actually go into a lot more detail about how to apply and develop the public health approach across a number of different settings. So initially these were tried and tested within the NHS. We've now adapted and rolled these out across multiple settings. So we've looked at education, we've looked at public transport, we've looked at even the retail settings, the nighttime economy. It sits really well across all of these. So there are, like I say, these level 3 and 4 qualifications that help people actually go on a training and development pathway, specifically around public health approaches. And all of this was underpinned by the publication of the Violence Prevention and Reduction Standard in 2020. So if anyone wants to really get their nose into the kind of mandatory, and it's embedded into the NHS contract now, is that everyone, especially who's contracted within and as part of the NHS, should be working to and aligning to this new violence prevention standard. I say new because big cogs can turn slowly. So although it was published in 2020, we know that for a lot of people, there's still quite a bit of work to do to try and align and work towards this. So again, if you're not familiar with it, it's worth possibly having a look at this standard. Reasons for taking this approach. So yes, we want to be proactive in prevention rather than reactive and punitive in our responses. We want to address the root causes of what can increase the risk of violence and abuse. We want to try and reduce the us versus them culture that can be a trigger or a risk factor around increased violence. Ultimately, we want everyone to be safe and feel supported. Specifically, we do want staff to feel safe in their work and be able to come to work without fear of violence or abuse. But really, I think it's wider than that. I do believe that it's about helping to keep everyone safe and reduce risk for everyone. And the public health approach, it is data driven and it is through systemic change at multiple levels. For people who've not come across or might be new to public health, I thought it might be useful to share what a definition or a couple of definitions of a public health approach. So the one that I really like is this first one that we've put up here. I really like the description of public health as the science and art of preventing disease, prolonging life, promoting health. And it's, again, multiple levels through society, organisations, communities and individuals. The bit that I really like is that it's the science and the art. So there's creativity in a public health approach. In many situations, we don't know what the answers are, but it's about trying to be creative and think outside the box for different solutions. And the science is that we underpin it with evidence and data. So hopefully that ticks boxes for people, whether you are more of a someone who likes the statistics and the evidence, or someone who likes kind of more creative approaches. There's something in there hopefully for everyone. And the other definition that we use is it's not about a single agency. It involves multiple public and social services working together. Pip's diagram or slide that outlined all of the partners, you know, it's a shared responsibility. It's never going to work if there's just one organisation or statutory service working to try and implement this. It really does mean that people come together and work as a united front to try and develop some of these approaches. So just to have a bit of a talk through the public health approach. The World Health Organization developed a 4-stage approach to delivering public health interventions around violence prevention. So first of all, what we want to do is define and monitor the problem. This is where the data comes in. So we define and monitor the problem. We do this mainly through reporting. So we need reporting to be accurate, and then we can look at what the data is telling us, what's happening, where it's happening, when it's happening, who it's affecting. And from that data, we can then identify risk and behavioural factors. So if we know what's happening where and why and who's involved, and we've got all of the data that we can look at, it helps us to pin down and really drill down into what's going on and trying to look at where these pinch points might be, where they sometimes described as hotspots, as to things that are going on. We then would be able to look at stage 3, which is to develop and test prevention strategies. So this is our creative element, the idea that we can think of what the art of possible, if you like. So being creative, thinking about what might help make a difference to the picture that we've been painted by the previous two steps. When we see that this is having a positive impact, then the fourth stage would be to take widespread adoption and rollout of the impactful approach. And I'm aware that this is all a bit hypothetical, so I will give you some tangible examples just to bring this to life as we go through. So here we have the 4 stages of the public health approach as defined by the World Health Organization. So define and monitor, look at the data, identify risk and behavioural factors, so looking at what the data is telling us and showing us, what picture is it painting. To develop and test prevention strategies, so to be creative in our approaches to the issues, and where we see positive impact to then adapt widespread implementation and rollout of the solution that we have tested. The other thing that the public health approach is based upon is something called the Ottawa Charter. It's called the Ottawa Charter because that's where it was originally drawn up and signed up to by a number of countries. So it was one of the first big international public health conferences, and it was held over in Canada in Ottawa. And all of the countries in attendance signed up to the Charter, and what they agreed in terms of a public health approach was that it's about building healthy public policy, so that very top level implementation, kind of top down approach, making sure that we are moving towards what is going to help people live in healthy and happy societies. So for example, at a public policy level, we'd look at things like the smoking ban, creating supportive environments. So this might be, for example, I'm trying to think of one in this country. So things like mapping and restricting or reducing the amount of fast food takeaways around schools. So making sure that or it could be a planning approach. So potentially making sure that there's well lit routes in and around high volume areas in towns or cities, making sure that people can move around safely. Reorientating health services. So an example of this that we've just seen in the new NHS 10-year plan is that there's a lot of talk about moving services closer to home and out of hospitals. So actually physically moving and reshaping how people can access services is another part of this public health approach. Developing personal skills, so this is about individuals being able to have increased knowledge and awareness, skill building, and helping people to make positive health choices. And then strengthening community action. So for things like this, we'd look at asset-based community development, making sure that we're looking at a strength-based approach, so looking at what is strong within our communities as opposed to what is wrong with them, and taking that kind of community empowerment approach. So these are the 2 models that we tend to look at when we look at public health approaches, and we will sort of bring them back more to the focus on violence prevention, but these are the overarching strategies. So we've got the World Health Organization 4-stage model, and we've got the Ottawa Charter giving us some guidance in this area. When we look at adopting a range of different public health interventions, specifically around the risk of violence, we know that there's the opportunity to have a positive effect on reducing and preventing incidents of violence right across the life course by lowering the chance of those involved in violence being involved again, and to ensure that those affected by violence get the support that they require. Just to give you a couple of examples where we've seen this being really effectively used. For example, we were working, try and give you a hospital example, a primary care example, or a community example, and then one from a different setting as well. So in a hospital setting, we worked with a dementia ward where they were having increased incidents of violence, and what they did was they went to the data and they looked at so in healthcare we use predominantly a Datix recording system. So they went to the Datix and they pulled all of the incidents that had happened over the last 6 months, and what they found was that it was closely linked to the time at which there was a handover of staff. So people on the dementia wards were becoming distressed at the time of staff changeover, and there was increased incidents of violence. So what they did, so obviously you can see here we looked at the data, identified what was going on, so stages 1 and 2. The third stage, the ward staff decided to implement an extended handover period. So rather than staff coming onto the ward and just doing a staff handover at the nurses station in a quick 5 minutes, they extended the handover time to a 25-minute period, where actually the new staff went round with the staff who were going off shift, and there was a physical handover with each of the dementia ward patients. So they were introduced to the new member of staff. And what they found was, over the course of that test period, the incidence of violence significantly decreased on that ward. And that was something that was then adopted more broadly across the dementia care pathway in the hospital. Another example would be when we were working with a school, and the school found that they were having increased incidents, like fights breaking out at the end of the school day. And it seemed to be whenever they looked at the incident reporting that was coming in, or where they had to potentially get the community police officers involved, it always tended to be at the end of the day. So their approach was, in the final lesson of each day, that the teachers or the delivery staff in the schools would give a reminder to children and young people about keeping themselves safe, moving towards the end of the school day, talking about, potential consequences if there was behaviour that was unacceptable. And again, when they revisited the incidents, they found that there was a reduction in the number of incidents towards the end of the school day, when it was sort of proactively discussed with the pupils as they approached the end of the day. So there are a couple of the examples where we've seen a public health approach be implemented. I think it's probably equally as important to talk about what a public health approach is not. And I would say this isn't necessarily something that's come from NHS England. This is what I've personally come across in the 3 or plus years that I've been delivering the level 3 and level 4 training, is that I think some people can be quite resistant to a public health approach where they see it being some of the things on this list. So I've kind of added this in to say, we want to be quite clear about what a public health approach is not. So we've said this already, but it's not a single agency responsibility. It's not in a silo. It cannot happen in a silo with one agency. And it's not solely a policing or enforcement issue. So quite often when I've been to work in hospitals, for example, the security staff have felt that it's been all put on them, that they are the only way that violence and abuse is going to be reduced. But we're saying no, it's not on any one individual. It's about whole systems and whole places even. It's not about being soft on crime. So where there are clear accountabilities to be taken, then it does not replace the criminal justice system with people, if they have been a perpetrator, have been dealt with in the appropriate way. What we're trying to, we know that there is always going to be, unfortunately, the need for that response, and that response is an appropriate one. We're trying to say, as far as is possible, we want to prevent that incident from occurring, but where serious incidents do occur, it is not that we are trying to be soft on or move away from people being held accountable where they need to be. And I think that's important, because sometimes when we're trying to implement or move into a public health approach, I think I have worked with people who felt like they're going to be left vulnerable, like if things do happen that they're not going to be dealt with, and that's absolutely not the case. So I think it's important that we try and have those conversations to reassure people we're going to do everything that we can to stop things escalating, to stop things happening, but where things do happen, they will be dealt with in the appropriate way. The public health approach, as far as is possible, is not focused on individuals. It's about whole populations. So when we talk about public health, it is a population health approach. So we're looking at the causes of the causes and the wider determinants. A public health approach isn't a silver bullet or a quick fix. We know that it's really challenging to change social norms, and that when we're working in this way, we can really be trying to rewrite some of the deep-rooted narratives and causes that can lead to increased violence. And we do not want to in any way normalise violence. We want to challenge the cultural acceptance of violence. We want to treat it as a preventable disease in the same way that we do with a lot of things with public health. So thinking of it as preventable, thinking of it as something that can be solved, although we know that there are many challenges to be worked through. So just having to think a little bit more about the underpinning principles. So I'm going to talk through a number of the principles that underpin a public health approach, because it isn't just, as we say, sort of linear. There are many layers to it. And the first one, as we've alluded to a few times now, is that we need to be constantly aware of health inequalities. So what we know is that violence shows one of the strongest inequality gradients, and within emergency hospital admissions that relate to violence, they are 5 times higher, 5 times more prevalent in the most underserved communities than in the most affluent. So if we were to think about our, for those of you in healthcare settings, the sort of core 20 approach, we know that levels of violence are much higher in our more communities more affected by health inequalities. So definitely always want to be thinking about the wider determinants of health and the challenges that people living in these communities or areas are facing. We always talk a lot about this on the training. So we talk about, what's the person's experience before they even engage with a service. If they've been coming to an appointment to see us, have they had to find a parking space, try and get public transport? Did they have the money to pay for the parking or to pay for the public transport? Have they been able to afford to put the heating on overnight? Have they been cold? Have they had an opportunity to eat that day? Have they got an empty stomach? Have they had a meal, been fed? So the wider health inequalities are always very much underpinning our approaches around violence prevention, and definitely something that we always want to pay heed to in the work that we do. Another underpinning principle that we want to have a think about is our adverse childhood experiences. And for people who, I'm sure most of you are, I don't want to teach anyone to suck eggs in this, but I'm sure many of you are aware of the adverse childhood experiences, defined as highly stressful, potentially traumatic events or situations which occur during childhood or adolescence. They can be a single event or prolonged threats to an individual's safety. And it links to basically, there's a really amazing book. It's called The Body Keeps the Score. And it's really about how these adverse childhood experiences in early life can play out into risk factors pertaining to the outcomes that people experience in later life. One thing that I always want to highlight when I talk about adverse childhood experiences and trauma-informed approaches, which we'll look at in a second, is that adverse childhood experiences, and you can see the list of them here, these are the ones that came out of the original data that was done in a huge study in America. I think there was over 10,000 people involved in the initial study, and it followed people over the course of a lifetime. It initially mapped their adverse childhood experiences as to how many they had experienced, and then followed them through in a longitudinal study to see how those adverse childhood experiences potentially played out and impacted across a life course. And what the data found was that those who had 4 or more experiences of adverse childhood experiences had significantly worse, not just mental health outcomes, but physical health outcomes, more likely to experience long-term health conditions and a range of more limited life attainment in terms of jobs, income, education. But what I want to just highlight and just to help people avoid falling into this trap is that the adverse childhood experiences should never be treated as a checklist. So yes, adverse childhood experiences demonstrate risk for people, but this was done at a population level. And population health data is very different to individual risk stratification. So this list should never be used working with an individual to kind of tick how many adverse childhood experiences does this person have. And because that does not automatically play out into, you know, the assumption that this is what life is going to look like for this person. Because what we haven't looked at there are the mitigating factors that may be there around that individual to offset some of the risk factors of adverse childhood experiences. A loving family, a supportive relationship. We know how important the trusted adults are for young people. You know, if they had a significant trusted adult, the mitigation of some of these risk factors can be significant. So I always give the example of thinking about so I'm sat here as a female in a cohabiting with my husband, and if we're to look at the population health data or the crime data, if we were to apply that from a population health level, the most dangerous person that any woman will meet in their lifetime is their significant partner, if that person is a male. So what that doesn't mean at an individual level is the most dangerous person that I've ever met my husband. At a population health data level, yes, that's what the data tells us. At an individual level, what that can never take into account is my previous experience of relationships, my previous partners, my husband's previous relationships, my, any mitigating circumstances. So I just get a bit concerned when I hear people using adverse childhood experiences as predictors for individuals, and just remembering that population health data tells us different things and doesn't ever look at the individuality that it does when we look at individuals. So when we work at a population health data level, it can be really helpful, and we know that people who live in some of these areas of being in underserved communities, that we know that this can play out into having more commonality and experience of adverse childhood experiences. So I said about trauma-informed principles. Here we've got our 5 trauma-informed principles. So we've got safety, trust, collaboration, choice and empowerment. And then there is a 6th element of trauma-informed practice. It usually sits kind of down at the bottom under empowerment, but I always put it up at the top of the list because I see culture as an overarching element of trauma-informed practice. So culture is are we culturally aware of different, you can go back to our protected characteristics around faith, spirituality, culture, race, sexuality, I forget them all off the top of my head. But really, when we think about trauma-informed practice, we need to make sure that the cultural approach is embedded, so that we're looking at people, taking into account the nuances of all of their different cultural aspects. And then we can look at our trauma-informed principles. So can we help people feel safe? Do people feel a high level of trust? Are we able to collaborate with people as opposed to that kind of us and them doing to people? You should be doing this, and turning that into a collaborative approach. Providing choice as far as is possible for people. So we talk a lot about this within the health service, but informed choice and helping people feel empowered ultimately to have influence over their own destiny, albeit that with continued collaboration with safe and trusted relationships, allowing them choice wherever possible. So the trauma-informed principles, again, are a really key part of the underlying principles of a public health approach. So how can we help people feel safe? with a high level of trust, that we're taking away that us and them approach to try and work collaboratively, that we try and ensure that people have choice wherever possible, and ultimately that individuals and communities are feeling empowered and in charge of their own destiny to as high a degree as possible. The next underpinning principle that I was going to have a look at is around upstreaming. And again, I'm sure some of you will have come across this before. So what we want to have a think about is how can we upstream intervention as far as is possible. So we're thinking about promoting healthy environments, preventing injury and illness, trying to be less reactive to risk factors but be preventative. Because as we move downstream, what we see is a lot more high intensity inputs, if you like, so treating injury and illness, neglecting health inequalities, responding as opposed to being able to be proactive, and again addressing social determinants. So how can we get upstream with all of these things and try and help people? The old adage is, rather than pulling people out of the water downstream, we want to try and help people stop falling in the water. What's getting them to jump in the water upstream, so we don't have to pull them out once they get downstream. So trying to work in that upstream approach and that preventative way. And then the final one that I was going to have a look at with you is around emotional intelligence, or EQ. So a lot of you will know that we've got an IQ in terms of our intellectual quotient. We've also got an emotional quotient. So it's sometimes called EQ or emotional intelligence, EI. So I'm going to get you to play a little game with yourselves now and have a think about how many different emotions can the average adult name. So we haven't got the chat box available today because we're in this webinar format, but just have a think to yourself, maybe make a little note, maybe have a count up on your fingers. How many different emotions could you name? I'll just give you a second to have a think about that. And I wonder if you'll be surprised when I put the answer up. So the average number of emotions that an adult can name is 3. So we've got angry, sad, and happy. This research came out a couple of years ago now, and what was interesting, at the same time that I was looking at this research, there was a little bit of what I think was probably synchronicity, and I came across this quote within the same couple of days as reading this research, and it says, "The limits of my language means the limits of my world." So what we mean by that is, if we've only got a limited vocabulary to respond with to any given situation, then this is most likely the response that we're going to get. So when we talk about violence prevention, if we've got this kind of lack of emotional awareness or intelligence to be able to name emotions and to then be able to kind of respond as opposed to react in situations, then it can be quite limiting. So what we're looking at doing, and I do quite a lot of work in education around this, is helping young people to become more aware of the whole range of emotions. Depending on what research you read, researchers love arguing about emotions, and depending on what research you read, some will argue that there are 6, some will argue that there are 9, some will argue, and there was a book that I was reading recently, that there are anywhere up to 60 or 70. It depends what evidence you want to look at. So, but what we know is that there are huge complexities and diversities within our range of emotions. There's some really lovely tools out there like emotion wheels, where you can actually kind of map different emotions and the different underpinning kind of things that can drive them. So as far, some of the work that we're doing is thinking about how can we help people become better at naming emotions to help them to better respond when things emerge. So for example, anger probably being the one that we will want to focus on within this work. actually anger can come from a number of different places. It can come from fear, it can come from frustration, it can come from boredom. They're really good in the prison system at trying to reduce boredom levels, and it's something that we were looking at how we could move that across into things like A&E settings where people have got really long waits. And there's some quite interesting learning from the prison systems where if people have to go on lockdown for significant periods of time, they are actively trying to reduce levels of boredom. So is there learning that we can bring across from different settings? So I was saying, so anger can come from different places. It can be boredom, it can be fear, it can be frustration, it can be not feeling seen or heard. Yeah, so that kind of ego link as well. So again, this is one of the underlying principles. And then just to finish off with, we have got a bit of time for a Q&A if people are wanting to get involved in that. I thought I'd just finish on a case study, and this is one that I've just lifted from the level 3 training that we do. So it's a young adult who's grown up in a house where they've witnessed domestic abuse. They're frustrated by being unable to make an emergency appointment with their GP. So they're in the surgery, they're trying to speak to the receptionist and book an emergency appointment, but they're being told that they're not able to. They use some choice language, and they're told by a fellow patient to mind their language. With hearing this, a security guard comes over to intervene and puts his hand on the young adult's shoulder. So the way in which we use this case study, obviously there's an immediate kind of response there from security. But the way that I always describe a public health approach is that we need to zoom out. And it's not just about the potential perpetrator of an incident. It's about everyone who's involved in that incident. So in this case study, we've got the receptionist, we've got the young person, we've got the patient who's sat in the waiting room, and we've got the security guard. So when we take a public health approach, we want to try and zoom out and have a look at this whole situation. So it's not just about focusing on the young person or the security guard and how they've reacted. But what we want to do is try and take an overview of everything that's going on. What's the environment like in the waiting room? Has that young person been able to have a private conversation with the receptionist to try and address why they need an emergency appointment? I don't know the last time that you've been in your GP's trying to get an appointment, but the way that I went in recently, and the waiting room was absolutely silent, and there was an older gentleman at the reception trying to make an appointment, and the receptionist did what I believe is quite a common thing of saying, why do you need the appointment? And they were expected to say a really personal thing in front of a waiting room with 5 or 6 people in it. And I live in a really small village, so they may well have known people in the waiting room. You know, so when we think about our trauma-informed approach, is that a fair thing to ask someone? And how do we expect someone to react in a way, if they're already feeling unwell, maybe they're in pain, and then they're asked to disclose what could be a really private, sensitive issue in front of other people. So how is this whole situation being set up? Has that young person witnessed, abuse or domestic abuse in that morning, in that 24 hours? How long has the receptionist been on duty? Are they fatigued? Have they already tried to deal with 20 patients wanting an emergency appointment and had to say no to them? What about the security guard? What's his experience? What's his training? In many situations, security guards really don't have a lot of training around sort of trauma-informed practice and the type of things that we've been thinking about. They'll quite often have restraint training and things like that, but is there the opportunity to do some training and development there? We know that probably putting the hand on the young adult's shoulder wasn't the right thing to do in that first instance. It could create quite a large response from the young person. But we don't know that security guard's experience. Have they seen a receptionist being verbally or physically assaulted in the last few days or week? So it's trying to take this non-judgmental approach to, and I always say when we talk about being non-judgmental, the antidote to being judgmental is to be curious. So for me, if I'm being curious about a situation, I always go in with, I wonder why. I wonder what's gone on for this person in this situation. I wonder why this person's reacted in this way. And then when we start trying to unpick what's happened in any given scenario, we can take that non-judgmental approach to try and help us understand as much as possible. Versus the kind of judgmental approach where, again, just thinking about my own approach, if I hear myself going into judgment, it tends to be, oh, well, they shouldn't have done that, or they should have done this. And there's no curiosity there. I'm very much in my own judgment about the situation. So can we stay, as a public health approach, we always want to be curious about what's gone on and how we can try and understand from everyone's perspective. Okay, so I hope that's been of some help. We did have a couple of questions submitted from when people were signing up to the session. So the first question that we had was, how will you know if a public health approach is working? Great question. So what we tend to find, if you think back to the World Health Organization 4 stages of a public health approach, what we know is that stage 1 is really important, and that's the data collection. So we need people, and we need to support people to really effectively report incidents which are happening. We know, I can talk more confidently about the health service, but we know that in the health service, violence and abuse is underreported because people have unfortunately become normalised to it in some situations, or they sometimes say, will say, oh, it's part of the job. We want to challenge that and say all incidents should be reported. Systems need to be accessible so that it isn't too labour intensive and time consuming for people to make reports when incidents have happened. And then what we should find, or what we can tend to find, is where people have increased their reporting. That in itself can be a positive outcome of a public health approach initially. So we might actually see that the data and incidents increase, and that then gives us a clearer picture of what is actually happening. So when we get to stage 2 and stage 3 of looking at the data and trying to put in our creative responses to the data, that we've got a more accurate picture to respond to. I think sometimes the data can be not as full as it can be. So usually what will happen when we apply a public health approach is that people will see an increase in reporting because people are becoming more aware of it, and it's been put on people's agenda. See an increase in reporting before we see the impact of an approach being taken. So yeah, initially we might see an increase in incidents. That would be an indicator that things are shifting and are changing, and then hopefully what we would see in time is that there would be an overall decrease in the amount of incidents going forward. So hopefully that answers that one. And then the second question was a bit longer, so I took a picture of it. Let me see. So this one's quite complex, and I'd be interested to see if anyone's got an opinion on this. So it said, how do we ensure we don't try to address extreme symptoms of violence to the detriment of working on the more complex root causes of violence? They go on to say, for example, treating showing adolescence in schools as though it is a wraparound intervention on violence against women and girls. So how do we ensure that we don't try to address extreme symptoms of violence to the detriment of working on more complex root causes? So I'm going to take it in 2 parts because it's quite a big question, that. So how do we ensure we don't try to address the extreme symptoms of violence to the detriment of working on the root causes? I think we need to be doing both at the same time, is the answer to that. So a public health approach doesn't mean that work in terms of extreme incidents stops. They're both going on at the same time to try and overall reduce risk and incidences. So I think it's been very clear that while we're doing the more complex work of unpicking the root causes, of doing things like asset-based community development, of building in trauma-informed approaches into our communities and into our services, that we need to then still have the appropriate responses to the extreme symptoms where they occur. So that would be my thoughts on the first part of the question. And then the second part is, how do we feel about treating, showing adolescence? So for people who aren't aware, Adolescence is a Netflix series which honed in on a very kind of current topic around violence towards women and girls from young men who have been to some extent or a large extent radicalised online by kind of very misogynistic views. And for anyone who has seen it and who works with young people, what happened was the Netflix series aired to great acclaim, and rightly so. It's an amazing programme, and it raises serious and important issues. But then the initial knee-jerk reaction was we should show it in all schools to young people. And my response, and the response of a lot of large mental health and youth charities across the country was, no, please don't do that. In fact, do not do that. There was a real danger that young people would be watching very complex narratives and issues being played out without the appropriate response and without the appropriate support to have conversations to follow up on that. So that idea was not followed through. I think in terms of parents watching it, yes, absolutely. In terms of young adults who work with young people, absolutely. But I think, yeah, in terms of sort of rolling it out as a public health approach, it wasn't something that anyone, well, certainly not in the worlds that I work in, that anyone thought was a safe idea.